There's a court case in British Columbia right now that could have very significant implications for healthcare across the country. And today we're going to talk to someone who's very much involved in that case. Dr. Brian Day is the CEO of the Cambie Surgery Center in British Columbia, and he's also a past president of the Canadian Medical Association. Dr. Day, thanks for your time today.
Oh, you're welcome.
So why don't we start big picture? If you could tell us a little bit about your clinic, the types of services that you provide, and then also how you came to be involved in the court case and what it's all about.
So our clinic opened in 1996 in British Columbia. It's a multi-specialty clinic, so we do a lot of different types of surgery. We do a lot of orthopedic surgery, and we do a lot of work for the Workers' Compensation Board. We treat a lot of non-residents. We also treat British Columbians who come here because of long wait lists. But when we opened in the mid-90s, it was smack in the middle of a 10-year rule of the NDP government. And so that's kind of an interesting facet to how we opened. And we opened with their support because they recognized that things were going to have to change. As things have evolved, we've now, we're now in court because despite having operated for many years in around 2008, the nurses union decided to try and force the provincial government to act on the laws that existed then, because we were in violation of certain provincial laws that prohibit access to private healthcare. We always considered those laws to be unconstitutional, so they were, if you like, unlawful laws.
Mm-hmm. So the law said that correct me if I'm wrong, but the law said you couldn't open up a private clinic and provide services to the public and charge the public if the public system was also providing that. And then the union said, hey, let's try and use this law to shut your clinic down. Is that roughly what happened?
That's exactly what happened. And, there are various funny sides to the story. For instance, the commonest demographic of patients that we were treating, and still probably today, commonest demographic is a unionized worker. And so that's just the nature of union leadership. We've actually had polls of unionized workers that show 95% of hospital unionized workers support us. So it's the leadership that has forced the constitutional challenge, which we launched in January of 2009. So it's now 11 years, and this is one of the longest cases in Canadian history since we launched it. And we're now in our fourth year at the Supreme Court level, which is also one of the longest trials in British Columbia's history.
And I'll tap into your vast legal knowledge now that you have experience going through this, but correct me if I'm wrong, but there was a decision many years ago involving a clinic in Quebec called the Chowley decision, in which case they ruled that it was against Quebec's charter for the government to basically say, you as a patient can only use the public system and you don't have a private option. And that decision said, no, that's not right. A government can't keep people on waiting lists, famously saying that access to a waiting list is not access to healthcare. And your case is different in that you're applying for a similar kind of decision to basically open up the option for people to have the choice in the private system and have that apply against the charter so that there would be national implications. Is that right?
Yeah, so Quebec has its own charter, which is actually almost identical to the Canadian charter.
Yeah.
And there may be political reasons why, but the fact is that the Supreme Court of Canada, not Quebec, ruled that the laws that made private health insurance illegal in Quebec were a violation of the rights of Quebecers.
Mhm.
So our case, if you like, is asking, and will, when it gets to the Supreme Court of Canada, and is asking right now at the Supreme Court in British Columbia, should citizens who don't live in Quebec have the same protection of their health and well-being and lives under the charter that the Supreme Court of Canada granted to to Quebecers? Are we living in a country where we have the same rights across the country in terms of our constitution? And you're right, our case will be precedent setting for the whole of Canada.
So if I understand this correctly, if you're a young mom or dad in Winnipeg or Toronto or somewhere else in the country, and you're wondering, well, how does this affect me? It would mean that potentially they could have the option to go to private clinics if they don't want to use the public system in their provinces. Is that right?
Yes, but it's also, across the country, workers' compensation boards use private clinics.
Mhm.
And there's a paradox. So the interesting paradox here is that if you have an identical injury at work and then have the same injury outside of work, in one, you are legally allowed to use the workers' comp insurance, which is private insurance, to access timely health care.
Mhm.
Whereas those rights are not, you're not granted those rights if otherwise. And we can use the example of a disability insurer. So you might be a carpenter, and if you injure your knee at work, then yes, you can get a private MRI right away, you can get private surgery right away, and that's covered by workers' compensation private insurance. But the disability insurer is also a private insurer, and if you have an identical injury, say playing soccer, and still can't work, the disability insurer is not allowed to do what the workers' compensation board can do. So I think it's important for everyone to understand something that's quite startling in my mind, and that is that we are the only country on earth, like bar none,
Mhm.
that makes it unlawful for a citizen to buy private health insurance. There is no other country in which that law, in which such a law exists.
Mhm.
And what the Supreme Court of Canada ruled in Charlie is that a province cannot offer health care and then fail to fail to provide that care in a timely manner, and at the same time make it illegal for you to pursue your own personal options. And in other words, governments in Canada have taken the position that they own your body, that they control your body, that they are responsible for your health,
Mhm.
and there isn't an authoritarian or communist country on earth that takes a similar position, which is bizarre.
It does strike me as bizarre. I think our CEO had a good way of putting it the other day, and he said when he was talking to someone, he said, the government takes half your income right now, your various taxes and fees, and then they want to tell you what you can do with the other half. It
Yes. Yeah.
it does seem like a very overreach, or an example of overreach by the government to just really limit people's abilities to use their own money to improve their lives. And just in terms of the legality, like how is it that they ban private healthcare that you're aware of? Like, what are the mechanisms? Is it a legislation at the federal level, provincial level? How does that work?
Well, there are two components to the law on health, and you have to remember that Canada, in Canada, there are at least 14 health systems.
Hmm.
And if you cross the border, so if you go from Alberta to British Columbia or Ontario to Manitoba, you're in literally a different country when it comes to the law. So it's perfectly legal for an Alberta resident to have private surgery at a clinic in British Columbia, or a foreigner to have surgery at a private clinic in British Columbia, but not for a citizen. In other words, it is like the former Soviet Union, where visitors had rights that exceeded those of non-residents. And I mean, it is almost, it's very difficult to understand why Canadians have accepted this, and probably most of them have accepted it because they don't know about it. I mean, at any one time, maybe only 2 or 3% of the population are in need of healthcare in terms of needing a procedure. And so it's very, the healthcare system works fine as long as you don't need it.
So right now, if I'm understanding this correctly, because I'm an Albertan and you're a British Columbian, I can go to your private clinic legally and the government wouldn't care if I reached into my pocket and paid for a procedure. But if I were a British Columbian and I did the same thing, that's when they start to care. Is that right?
Yes, and that's exactly right. And there are some interesting, you might call them hypocritical parts to this. We at our clinic have treated federal employees who live out of the province, including politicians, judges, and so on, where we have received payment from another government that's in court fighting against us, like the federal government, when they are actually funding patients here to come here. We have had the nurses union that launched the action that precipitated our constitutional challenge has sent patients to us. The defendant in the trial is the Attorney General of British Columbia. Attorneys General are on record in the news of having gone and used private clinics themselves. The Attorney General Office of BC sends us patients. This is what I call the hypocrisy, or maybe it's just ignorance of knowing. And part of the problem is it's not recognized until it applies to you. And we've seen this with many examples. We've treated patients from a wide variety of backgrounds who, until they needed the healthcare, were against. There's a group in court against us called Canadian Doctors for Medicare. It's a fringe group of a small number of doctors compared to the number of doctors in Canada. Their leaders, some of their leaders, have been treated at our clinic. They are interveners against us in the trial. This is how crazy this hypocrisy is. But there are people sitting in the courtroom opposing us, who've had surgery at our clinic and paid for it.
It's I can see you got a full head of hair there. It's amazing that you haven't pulled it all out by now. Just the craziness of people that are, like you say, in court trying to shut you down while at the same time calling up and saying, yeah, can you take a look at my knee or whatever the case is. It must be extremely frustrating. I want to shift a bit and talk about the rationing that goes on in Canada's healthcare system. I think there's two types. The first type would be when the government says, we're only going to fund, you have politicians and bean counters saying, we're only going to fund, say, this many knee procedures this year. And then, of course, obviously, if you're the one who's left out, well, you have to wait a while before you're going to get that. So they ration how much service they provide. Are there any stories patient stories? I mean, I know obviously you wouldn't say any names and we wouldn't expect you to, but are there any examples that stand out in your mind?
Well, I mean, in parts of Ontario, for example, patients have been told that the surgeon cannot do any surgery for another few months because of exactly the process you've described. We have in evidence in British Columbia directives from the hospital through the health authority and through the government that they've gone over budget. And so in addition to statutory holidays and weekends, they are closing all non-emergency operating rooms for an additional 10 days a year. Non-holidays, non-weekends, an additional 10 days a year. This morning, I saw a patient from Ontario who's desperate and is facing a very long wait. I personally operate on 2 or 3 Albertans a week who cross the border. There is there are remarkable stories of a surgeon, this is under the previous Alberta government, who was so desperate that he and his patients were getting on a plane traveling to Turks and Caicos to have shoulder surgery, and then he came back at a private clinic in Turks and Caicos. So this is how ridiculous it is. And I know that your group has done research on Canadians traveling abroad for surgery.
Yeah, and one of the stats that we were able to crunch, and it's a very, very low-balled conservative estimate, was that there were that Canadian patients made over 217,500 trips outside the country specifically for healthcare in 2017. And, you know, it's mind-numbing to think of that many people. I mean, that's more than the population of Kelowna, BC. It's just a huge, huge number. And we kind of looked at it from the economic perspective. I mean, every time a patient goes abroad, they're taking money out of Canada's economy, and those dollars could have been spent here to employ people, companies that would pay taxes, which could actually help the public system. But just on that point, one of the shortcomings with the data is it doesn't tell us the why. I mean, we can surmise that people are going abroad because they don't want the long waiting lists. In other cases, it might be that they feel they're getting potentially a superior service, or a service that is not offered here. With your clinic, it would be kind of similar in that you're kind of taking people that do not want to use the public system in BC or other parts of the country, so they're going to your clinic. Do they tell you why? Like, is there a predominant reason as to why patients are coming to the clinic?
Oh yes, it's the wait. It's the long wait. So I mean, there are very good surgeons in Alberta and Ontario, and we've had patients from as far away as Newfoundland. There are good doctors. It's the wait. And you know, just on the story you were talking about, I once in a former NDP government in British Columbia, at an open forum, I said to chief operating officer of the associate deputy minister, I said, and this was in regards to BC residents going down to across the border just south to a private MRI clinic.
Mm-hmm.
And I said to her, isn't it better for the patient, for the economy, that instead of two-thirds of the patients at this MRI clinic in Bellingham, which is just south of the border in British Columbia, 2/3 were British Columbians. I said, wouldn't it make sense to open allow a private MRI clinic to open in British Columbia, and you'd keep the patients here, the jobs here, the revenue here, the taxes here? Because one of the things private clinics do, which the public don't, is we pay taxes to the government. So we're a source of revenue for the government. Wouldn't it be better to keep the patients here rather than having them go across the border? And you know what she said?
No.
If I could stop them at the border, I would. In other words, that is the authoritarian view that governments take about patients. They really do believe that they should be in charge of your body. I mean, it's just, and this is why if you travel elsewhere to another country, people actually hardly believe. I was invited last June to go and speak to a group of international health executives from around the world in Budapest.
Mm-hmm.
And the reason they invited me is these are delegates from South America, Australia, New Zealand, Russia, China, Europe. The reason they invited me was they couldn't believe that private health insurance was unlawful and that we were launching a suit to get it. After the meeting, or after my talk, I opened the conference. After the talk, 5 delegates came up to me from communist China, from Beijing.
Yeah.
And they said, this is crazy. No Chinese government would dare to do this. Wow. To outlaw private health insurance. And it's true. Like, so we have a situation where ideology has kind of gone crazy in this country, mm-hmm. Specifically on the topic of healthcare, because no one is proposing that we close down private schools, or, I mean, you know, all of the things that are important in society, like housing, nutrition, education. No one is saying the government should take over housing and food outlets and education, and outlaw personal options. And what we're saying is that, yes, low income groups, those in need, low income seniors, should all, we need to take care of those as a just society. But we don't need, you know, this idea that we need to, that all seniors need special benefits. Like, I happen to have, because I'm over 65, I have a gold card that gives me added benefits over younger people in British Columbia, just based on being over 65.
Yeah.
That's ludicrous, because 2/3 of the wealth of the country is in the hands of those aged over 65. And yes, we should be subsidizing low-income seniors, but we should be subsidizing low-income young people as well, who can't get access. And that's what happens in the rest of the world. And you know, it's actually blinkered vision of our politicians, and our politicians are afraid of it. When I debated last year, or just over a year ago, with the Quebec health minister on this very topic, and he has been quoted, like you alluded to, saying the budget's gone, no more surgeries. Like, he came out with a directive like that. After our debate, though, which was in front of a big audience in Montreal, he came up to me and he said, off the record, so I'm now putting it on the record,
I guess so.
every health minister in Canada wants you to win this case because they don't know what to do.
Wow.
And that's what we're facing. We're facing a situation, like, whatever side you stand on when it comes to, say, the safe injection sites, assisted dying, same-sex marriage, abortion, whatever side you stand on, whenever something like that arises, politicians are afraid to come out with a decision, and they move it to the courts because they don't want to take the heat. And that's not what we elect governments to take the heat, and they're not doing it. So this is a weakness of government. And as I say, politicians from all parties are to blame for this. I'm not just blaming NDP or Liberals or Conservatives. It's all parties. They are, but and I think there might be a glimmer of hope in Alberta with the new government. They may be taking some initiatives that they need to, that we need to, that every province needs to, because there are countries around this world with much greater social programs than we have, like Denmark and Sweden and Holland and Norway, that have a hybrid system, and they look after the low-income groups. They look after, in Canada, one of the biggest paradoxes, and this is Canadian government data, the worst health access and the worst outcomes are in low-income Canadians. Yeah. There's something wrong there. There's something wrong.
It's very frustrating in this country that when you talk about healthcare and trying to improve our system, immediately it comes down to the two option scenario: keep our model or go to the US. And you know, there's 200 countries on this planet. It's appalling that we can't look at some other developed nations, like you say, European countries, Australia, New Zealand, and find somewhere that is a similar country to Canada that has better healthcare system. It's frustrating.
And the US system, all they need is to offer universal healthcare. The hospitals are great. No one is running down American hospitals, but they're inefficient. They're, you know, the Commonwealth Fund, together with the Canadian Institute for Health Information, which is a Canadian government-funded body, rated Canada 10th out of 11 developed countries, and the US 11th out of 11. So we're down at the bottom of the pack with the United States. So I don't think, if you're in a hockey league, the two bottom teams wouldn't be looking to emulate each other. They'd be looking at the top teams, and that's what we should be doing.
Exactly. You know, your point about people going across the border to for MRIs, myself and Chris Sims, she's a contributor with our organization. We got in a car one day in Vancouver, drove across the border, went to private healthcare complex, drove around, and we filmed it. We put a video on our page, and you can see all these BC license plates. And
Yeah.
I kept hearing dollar signs every time I saw them because they're taking money out of our economy. And obviously, you can't blame people for trying to improve their own health. I want to come back to the second type of rationing that I see, and that is that the types of procedures that are available. Because I've often heard from different people that are in the healthcare sphere that, you know, sometimes doctors will have a choice. If you're trying to fix a problem, you can use one option or another. Sometimes one costs more, but it's less invasive for patients than the other. And yet governments often will choose the cheaper model because they're trying to scrimp on costs, and they're not as concerned about the effects on patients. How much of that do you see in your experience? Does that happen a lot, the rationing of the technology and the procedures that are available?
Yeah, so one of the two reasons why we set up our clinic in the mid-90s was, number one, hospital OR time was being cut, in my case, from 22 hours a week to 5 hours a week, and yet I had over 400 patients waiting to get into hospital. And the second was technology. So we were, we were at the forefront. We're at the university. We're at the forefront of we're teaching and research, and at the forefront of our profession. But when we went to other countries, Europe or the United States or Australia, and saw that they had equipment that was far more technically advanced than ours,
Mm-hmm.
it frustrates us that we weren't even able to teach using the most modern equipment. And that's one of the reasons we set up our clinic, and we bought new equipment. So to give you an interesting anecdote, one of the patient that came to see us was in need of a hip procedure, and they had a loose piece of bone in their hip. And we had the equipment to take this loose piece out with using very minimally invasive techniques with hip arthroscopy. They didn't have the equipment at the university. And so we asked the government to fund just the equipment and nurses so that this person could have it taken out at our clinic, and the doctor would just be paid the same as at the university. They wrote back saying no, they found out that you can take this out by opening up the hip. In other words, they said no, because you can get the loose body out through a 10-inch incision, that there's no advantage from their perspective of, and the patient would have to stay in hospital for 3 or 4 days. No advantage to having a day surgery procedure, and so they're not going to allow that.
Wow.
But we did shame the government into getting modern equipment by me publicizing the fact that we were lending our technologically advanced equipment to the public hospitals at no cost. That leveraged them. But this has its roots in the funding system of hospitals in Canada, mm-hmm. which is again unique. Mm-hmm. The OECD has pointed this out, that Canada block funds its hospitals. So a hospital in Canada gets its annual budget, and out of that annual budget, they treat patients. And when the money runs out, or they can't buy new equipment and they can't treat patients. So uniquely in Canada, if a patient goes to a hospital under the public system, mm-hmm. the patient is using up the government's money,
right?
The hospital's revenue. In the National Health Service in Britain or in New Zealand or in other developed countries in the OECD, if a patient goes to the hospital under the government-funded public system, the hospital receives revenue.
Yes.
So in other words, hospitals want patients because they bring their revenue. A hospital that treats no patients gets no revenue. Mm-hmm. And the same applies in the emergency departments. Patients going to an emergency department bring revenue in other countries, but not in Canada. And it's public revenue. We're talking about the public system here. So guess what? So when a hospital here is getting towards the year end, they stop treating patients or cut back on hours or close down operating rooms. And if you did that, if these hospitals that do that were in Europe, they would go bankrupt because they'd have no revenue to pay their salaries and operational costs. So we have a bizarre and non-patient focused system of funding our public hospitals. And the reason the governments have that is because of the limited budget. There's no mechanism for increasing the funding of an annual budget. So
incentive model, isn't it? Under the other
yeah.
model, then you incent people to actually get procedures done. Whereas in Canada, it's here's a whole bunch of money. Good luck. We hope you provide a lot of services.
And so the chief financial officer of a hospital in Canada is looking to cut services when their budget's tight, whereas the chief financial officer of a facility elsewhere in the OECD is looking to increase services when budgets are tight.
Right. That's a very different model. So I guess the takeaway is that in the meantime, until Canada changes, you don't want to get sick towards the end of the year when the government's cutting or the hospitals are cutting back on hours and procedures, do you?
Well, you don't want to get sick anytime in our system. You know, we haven't talked about patients, but in our case, it's people, and especially the government, tries to portray our case as a clinic taking action against these unconstitutional laws. But we had 6 plaintiff patients.
Right.
Sadly, 2 of those patients have died during the long wait to get to trial. But of the remaining 4 patient plaintiffs, 3 were children. And some of the worst access problems in Canada are in children.
Yes.
Happens, which is terrible.
Yeah.
But one example of a plaintiff in our case is a young was a 15-year-old boy who had a spinal condition, but was able to ride his bike, play football, but progressive spinal deformity and needed spinal surgery at the BC Children's Hospital. Ended up waiting 27 months when the maximum he should have been waiting was a month or 2. Waited 27 months to get into hospital and ended up paralyzed for life. That is not defensible in any developed country. Another was a young woman who was looking at a scholarship for sports in the United States from a lower income family, and ended up with a knee injury, and the scholarship was at stake. In other words, the child's whole life under threat because the parents couldn't afford to send them to an expensive university, get a free education and pay for an education, but because that person was put on an 18-month wait list, that would have been the end of their hopes of getting a scholarship to get educated. Patients like that, the government and the lawyers in our case don't want to go anywhere near them because they keep trying to focus this as, quotes, a private clinic. And one of the things I like to point out is the founding shareholders of our clinic, who've made very little return on their money. They've gotten their money back, but not much more. So the founding shareholders of our clinic have donated over $100 million to the public health system in British Columbia.
Wow.
By philanthropists. There's a new St. Paul's Hospital being built downtown in Vancouver. 2 of our founding shareholders were the trustees for a group called Esperanza that owned the land that the new St. Paul's Hospital, the big hospital in downtown, is being built on. They bought it for 20 million, 20 odd years ago, and
Mhm.
just sold it to the government for $20 million. No inflation. By the time they sold it, that land had appreciated to $240 million.
Wow.
They gave it to the government for $20 million. And to say that these individuals are trying to profit from the health system is just, it's an insult to what they've done and what the families have done in terms of supporting the public health system.
That's incredibly generous in both of those examples. But yeah, it's amazing that the way that the case is being portrayed and the way that the private healthcare is positioned in Canada, because as we've talked about, it's so common in the rest of the world where people have the choice, public system. And if you don't want to use the public system, well, you can use the private system.
The most important reason for that is not so in England, for instance, which is a system and on which our system was based,
Mhm.
Only about 10% of the 10% have private insurance,
Right.
but it has introduced that element of competition that
Mhm.
makes the public system accountable. Because in Canada, you have nothing to compare your 18-month wait to. But in England, so my sister was visiting recently before Christmas and has just had a hip replacement in England under the National Health Service.
Mhm.
She was angry because she had to wait 7 weeks for her surgery. And in the private system, it would only have been 3 weeks.
Yeah.
So it does, it just shows you that, but what you can be sure that there's no way they could let it be 18 months
Yes.
because there'd be an uproar. But
Yeah.
the reason that the government has the government hospitals in the UK have to conform to a higher standard is that there is something for the public to look at and say, wow, look how well they're doing.
Yeah.
And we face that all the time. In our constitutional trial, one of the government experts came out with a statement that we know in Germany, where there's a public and private system, that an MRI in the private system takes twice as long as in the public system. Well, it was something like 6 days in the private system and 14 days in the public system. But they didn't use those figures. They just said twice as long. Now, if you could get a public MRI in 14 days in Canada, you'd be looking at a pretty good system, but
Yeah. Yeah.
we don't. Yeah.
Well, I laughed when you said she was upset about 7 weeks. I'm sure it was still difficult for her, but for perspective, the first patient story we did was a lady in Vancouver, Jenny McKenzie. We put the video on our site if anyone wants to watch it. But she was told that her wait would be anywhere from 1 to 2 years.
Yes.
And it was, it's sad. We focus on the patient stories because we really need to humanize these stats that are out there. I mean, these are everyday people paying their taxes into the system and then going through some very, very difficult and sad situations. I mean, she told us about living in constant pain. She was an active senior citizen before all
Yes.
the problems began. And then she was confined to her apartment. Putting on her socks was hard, et cetera, because of these tremendous hip problems that she had developed. And, to be having to wait 1 year to 2, I mean, you wouldn't wish that on your worst enemy. But
Yes. One of the other plaintiffs in our case was an elderly patient in her late 70s who actually had terminal lung cancer, and she'd had one lung removed, and but she was actually functioning fairly well. Like, she could play 9 holes of golf, had a dog that she took for walks,
yeah,
and but she had a life expectancy of about 18 months. And on playing golf or taking a dog for a walk, I forget which, she tore a meniscus in her knee and was housebound. She was looking at an 18-month wait to get her knee fixed. In other words, sentenced to life house arrest.
wow.
And so she had her surgery done at our clinic and went back to playing 9 holes of golf and walking her dog. And so she had 18 months of enjoyment where she would have been institutionalized in her home
Yeah.
because she could hardly walk. And that's that, as you know, in the Chowley case, the Supreme Court of Canada ruled that Canadians were suffering and dying on wait lists, and that was held to be unconstitutional. So people are dying as they wait.
And that's the next point I want to talk about. You had a tweet, I think it was around Christmas time, where you suggested that there were about 6,500 people a year that were dying from waiting lists in Canada. Could you tell us a little bit about how you came to that number? And
yes, well, they're dying on waiting lists. So it's in evidence in our trial. We got the statistics from Fraser Health, which is one of the biggest, if not the biggest, health region in British Columbia. They service 1.8 million people. So in 1 year, 308 people died at Fraser Health. This is the hospital's own figures. They were removed from the wait list because they died. Now, if you extrapolate that to Canada, that turns out to be almost 6,500, assuming, which I think it's safe to assume that they're a good health region and they're not worse than anyone else. It's safe to assume their experience is representative of Canada as a whole. 1.8 million, 308 died. You extrapolate that to Canada, and it's 6,500 patients a year, which, and if you extrapolate it since when we started the trial in January of 2009, that's almost 72,000 Canadians have died on a public wait list to get into hospital. Now, they didn't all die because of the condition for which they were waiting. They might have been like the lady I talked about who was housebound, waiting for a knee operation, and happened to die. Well, it's a terrible thing to extrapolate, but it's true that actually it's cheap for governments to have patients die on wait lists. It couldn't cost; they don't have to pay for the procedure, and for sure, of those 308, which if you extrapolate it to Canada, is 18 people a day dying on wait lists. For sure, some of them are dying and the cause is the condition for which they're waiting. And it actually is just reinforcing what the Supreme Court of Canada said, that patients are suffering and dying on wait lists in Canada. They ruled that in the Chowley decision. And this is not a right wing, this is the same court that legalized same-sex marriage, legalized prisoners having the vote, legalized abortion, legalized assisted dying. These are not the actions of a right-wing court. So this is what the Supreme Court of Canada said, and we're basically, as I said earlier, we're in court saying, if you're suffering and dying on a wait list and you don't live in Quebec, should you have the same rights under the Charter that the Supreme Court of Canada ruled Quebecers have? That's what we're saying. And is it lawful for a government to promise healthcare in a timely way? Because timeliness is one of the. Is it lawful for a government to promise timely healthcare, then not deliver it, and then remove the legal right to extricate yourself from that pain and suffering? That's what our court case is about.
Yeah. I like your summary there. I think you're missing one point, and that is that not only are they not providing the service, but they're taking your money for it. So they charge you in taxes.
Well, I think that the studies have been done, as you know, and this calling it free healthcare when the average family is paying something like $14,000 a year for health costs out of their taxes. $14,000 a year is a lot more than you pay in most countries. And if you look at what Canadians spend compared to countries like Denmark and Sweden and Belgium, we're spending a lot, and yet we're ranked near the bottom as a health system. And we're spending a lot and getting little for it. The other thing that you will hear demonized is this private system. But a lot of people don't realize there are countries out there I lived in Switzerland for 6 months. Countries out there like Switzerland and Holland, where the universal health system is based on private insurance and private hospitals. So what happens is it's compulsory to buy private insurance.
Yeah.
But if you can't afford it, the government pays the premiums. So you don't have the government as the deliverer and in control of your health. You have them in charge. So for instance, in Switzerland, which has one of the best health systems in the world, a low-income person who's or gets the private health insurance paid for by the canton, the government, and that person gets the same private room and good food and private hospital that a wealthy person gets. You can have universal healthcare and the government can be completely out of the picture except for paying for the premiums. And in a way, that's an option open to governments here. You know, when they say, oh, well, it will bring inequality. Well, we have inequality when it comes to prescription drugs, when it comes to physiotherapy and dentistry. It's crazy that we don't cover dentistry. An abscess in a wisdom tooth can penetrate through to the brain. There is no logical reason why we have a medical system that doesn't cover your teeth. There's no biological reason as a biologist. There's no logical reason that you can explain to me if you're hit by a truck and are lying on the side of the road with multiple fractures, why the ambulance to take you to hospital is not considered medically necessary, and therefore we don't pay for it because the government doesn't pay for it. And there's no and if you go to your doctor and are diagnosed with a serious infection with pneumonia, how do you explain the fact that the drugs to treat the pneumonia are not considered medically necessary? You have to have private insurance or pay for them. So these are all clearly arbitrary separations, and we're one of the few countries with universal healthcare that doesn't cover dentistry, drugs, ambulances, and so on. And it makes no logical sense.
So on that note, and it makes for a good segue, what if you're the Minister of Health and you've got all the power, is there a country out there where you would say this is the one that Canada should copy?
Well, I don't say we should copy any one country, but we have a unique opportunity here if we win our lawsuit. And by the way, a vast majority of Canadians want us to win this lawsuit. Ipsos did a poll in 2018, showed it's 76% across the country, 80% in British Columbia. And I always say it's a strange form of democracy in which the government is fighting against 80% of the people. But there is a fellow called Mark Britnell who's written a book on healthcare, and he has he has a chapter on the world's best health system. And what he does is he identified 12 countries and one component of each country that he would introduce to make the world's best health system. Canada has the opportunity to do that. So, for instance, there were countries like Singapore, Norway, Germany, France, England, and even the United States was there for technology. And I think it's, we all run down this, the terrible United States, but we can't argue with the fact that some of the best healthcare in the world is available in the United States. And that's why our politicians often go down there when they need healthcare. That in fact, if you look at a group out of Spain who ranks hospitals worldwide, something like over 90 out of the top 100 are based in the United States. So they have good hospitals. They just have they just need to make it universal. And so I would say what you have in Canada is a unique ability to take maybe not Britnell's 12, but at least look at them and say, I'm going to copy the best of that. I'm going to take that. I'm going to take that, right. and develop. We have a chance here to create the world's best health system, because right now it's an old ranking, but the World Health Organization ranked us 30th in the world when they last did rankings. The Euro Consumer Health ranked us 23rd compared to 29 alongside 29 European countries. They ranked us last of those countries in value for money, and so there is an opportunity to move up the rankings. And we're next to bottom when it comes to the Commonwealth Fund and the Canadian Institute for Health Information. We should be able to get up in the top 5 if we introduce a bit of competition for the public health system.
Well, that's interesting. And I think you're right. I think there is an opportunity to learn from different models. And I guess it is more complex than to just say, okay, here's the one we need to copy.
Right.
I know I've taken a lot of your time, but one final question, and that is, are there any thoughts that you would like to add about anything that we haven't touched on yet?
No, except that that I think that the public need to be aware of what's going on, and they need to realize that until it's you or your loved ones, and that it's hard to understand what's going on in healthcare. And also anecdotes about success. Yeah, in Canada, a high percentage of patients, like over 50% or 60% even, do get, once you get into the health system, the doctors are good, the nurses are good, the hospitals are good once you get on the operating table. But it's getting there, and hospitals need to be incentivized. They need to, one of the things we haven't talked about really much is medical tourism, and it's one of the biggest potential industries in the world. We don't know where it is in terms of a dollar amount. It may be between $300 and $600 billion worldwide. We talked about the 217,500 Canadians going down to the States.
Mm-hmm.
A couple of million Americans go abroad for healthcare.
Yeah.
Canada could offer that healthcare at a very much discounted rate compared to the United States, and yet with our biggest trading partner, we're not involved in that business at all. So our public hospitals could open on Saturdays and Sundays and nights and evenings and generate revenue, which is what happens in England, and it happens in other European countries, happens in Cuba, where you use the revenue to enhance the funding of your public system. And that's a massive industry that's potentially out there for Canada. But right now we cannot engage in it because we have massive wait lists.
Yeah, and that's a good point. A former politician in BC raised that very same idea. Renting out public facilities when they're not being used, take those dollars, pay for the public system. It's kind of similar to our post-secondary system, isn't it? You go into a post-secondary institution in Canada, and it's very common to see lots of international students that are helping to pay to support the public system. But
right.
Anyway, that's a whole other can of worms. I think you've raised a good point, though. But I want to thank you again for participating in this. It's very interesting. And if anyone has any questions or they want to learn more about your case, where can they go for information?
Well, the Canadian Constitution Foundation has a website. It's called theccf.ca, THECCF.ca. And then there's another website called charterhealth.ca. And they have some information on it, but it's going to be, if you just Google the Canby case, you can read a lot about it.
Okay. Perfect. Well, thanks again for your time.
Okay. Take care now.